Doctors, this is Dr. Ashish Prasad from the medical team of USV. It is a pleasure to welcome you to today's Indo Global Talk Show on the triple fixed dose combination of dapagliflozin, sitagliptin, and metformin, featuring the renowned expert in the field, Professor Ralph E. DeFranzo. Good morning, DeFranzo. Professor DeFranzo. As you're aware, diabetes is a major global health concern affecting millions of people worldwide. Today's event brings together a panel of esteemed speakers who will share their insights and expertise on the use of combination therapy in the management of diabetes. Professor DeFranzo is a world-renowned authority on diabetes and the recipient of numerous prestigious awards for his pioneering research in the field. He will be joined by expert panelists from India who will provide their perspectives on the use of the triple FDC of DAPA, SITA, and MET in the management of diabetes. We are honored to have such a distinguished group of experts with us today, and we hope that this program will provide valuable insights and guidance to all those involved in the management of diabetes. Now, please let me introduce Dr. Piya Ballani Thakkar, our moderator for today's event, ma'am. I'll just share a slide. Dr. Piya Ballani Thakkar, as you all know, has a unique distinction of being both an endocrinologist and gynecologist. She is a consulting physician and endocrinologist at the Bombay Hospital and Medical Research Center, British Candy Hospital, and Dr. Ballani's clinic in Kolkata, Mumbai. She is founder, member, and honorary secretary of the Peace Society of India, and she has received multiple awards, as you can see here, and she also published multiple articles and chapters in several journals. With this brief introduction, I hand the session to Dr. Piya, who will introduce our eminent experts and take this talk show forward. Over to you, ma'am.
Thank you so much. Well, good evening, everybody, and good morning, Dr. DeFranzo in Texas. It is truly an immense pleasure and with humble privilege that I'm inviting all our delegates to this very special Indo Global Talk Show today. And why am I calling it special? Well, the reason is that we have more than 3,000 audience members joining us today in a phygital manner, which is physical plus digital. It is special today because we truly have a galaxy of experts. In fact, the experts of the experts are going to give us today, in what my opinion is going to be an ultimate academic enlightening show today that we're going to have. And more than that today, what we have today is our sponsors of the evening, USV. I think they're an Indian company with truly a global vision, putting forward together such a kind of, interaction between us. And of course, to top it all, we have with us today, Dr. DeFranzo. Welcome, Dr. DeFranzo. Good morning to you in Texas. And it is truly for us such a happy time to be able to talk to you one-on-one in this chat show rather than having it just as a presentation. For anybody who has studied diabetes in the last 40 years, well, DeFranzo and the pathophysiology of diabetes are always taken together in the same single sentence. And so today you are indeed for us an outstanding clinical researcher in our midst today. And of course, we welcome you, Dr. DeFranzo, like we're all aware, is the Chief of Diabetes at UT Health Science Center and a Deputy Director at the Texas Diabetes Institute. His major interests, like we're all more than aware, insulin resistance and the pathophysiology, treatment of type 2 diabetes, and this whole metabolic cardiovascular cluster of disorders that he has so well defined for us. And during his distinguished career, he has received so many distinguished awards. The Lilly Award from ADA, the Banting Lectureship in 1988 from the Canadian Diabetes Association. So that's so far back from when he's become the recipient of so many distinguished awards. The Novartis Award, the Banting Award from the ADA, the Claude Bernard Award from the EASD again in 2008, 2017, the Hammett National Prize, and also the distinction in endocrinology from ACE. Multiple articles in multiple peer-reviewed medical journals. A warm welcome to you, Dr. DeFranzo.
Thank you. Very kind invitation.
All right, we'll take that one step forward. I have a lot of distinguished faculty to introduce tonight. And again, it is today with extreme pleasure that I would like to introduce my co-Bombayite here, Dr. Chandalia. Dr. Chandalia, as we know him, is a teacher through and through, start to finish. All of us have had so many important lessons to learn from Dr. Chandalia over these many years. He is the Director of Endocrinology, Diabetes and Metabolism at Jayshree and at his private center at Denmark, Mumbai. Faculty, he remains very academically involved, faculty at the University of Alabama and at GMC. Multiple articles, multiple authorships, multiple editorships. He's the editor and the founder editor of the Journal of Diabetes in Developing Countries, the editor of Diabetes Today since 91, and the editor-in-chief of the RSSDI textbook of diabetes in 2015. Welcome, Dr. Chandalia.
Thank you. Nice to be here.
And then we next have Dr. Shubhankar Chowdhury. Well, Dr. Chowdhury is one of the best leaders of our time. He is the professor and head of Department of Endocrinology at 𝐕𝐥𝐸 and the SSKM hospitals in Calcutta, a subject expert for the government of India, a founder patron for SAFEs, the immediate past editor-in-chief of the 𝐈𝐧𝐝𝐸, the immediate past president of the Endocrine Society of Bengal, and the past president of the Endocrine Society of India. His research interests are multiple: the gut microbiome, GDM, pathogenesis of Graves' orbitopathy, biology of fat, with more than 200 publications in peer-reviewed journals. Well, a warm welcome to you also, Dr. Chowdhury.
Thank you. Very good evening.
Good
and
evening,
good morning, Dr. DeFranzo. Look forward to an exciting evening.
Absolutely. Dr. Bantwal, good evening, sir. Dr. Bantwal is an orator of great eminence. He's the professor and head of endocrinology at St. John's, the vice president of the Karnataka Endocrine Society, past president of the ESI, past treasurer of the Karnataka Endocrine Society. His oration, his simple, succinct, and the superlative style has won him many awards: the Dr. Nara Gowda Award, the 2014 RSSDI Oration Award, the Dr. Sunil Kumar Basu Oration Award, more than 100 publications, a principal investigator in multiple clinical trials. Dr. Bantwal, a warm welcome to you tonight. And then we have feminine power in our midst, Dr. Jayshree Gopal. She's the director of the Indo India at SIMS Institute for the Diabetes, Endocrine, Metabolic, and Lifestyle Diseases. She's a consultant endocrinologist and diabetologist at the Sitapathi Clinic, an associate dean for teaching and research at the MV Diabetes Research Center in Chennai. She's also the founding member of the IMS in the Chennai chapter, with multiple publications and authorships as well. Dr. Jayshree, welcome to you tonight.
Good evening, good morning, and thank you so much. Pleasure to be here.
Thank you so much. And then, of course, Dr. Rakesh Kumar Sahay. He is the professor and head of endocrinology at the Osmania Medical College and Hospital, and a consultant endocrinologist at his own Sahay's Endocrine and Diabetes Center in Hyderabad. He's had multiple presidencies: president-elect of the RSSDI, past president of the ESI, vice president of SAFEs, section editor of tropical endocrinology, fellowship of the ACE in 2009, multiple publications, more than 180, multiple authorships. Welcome to you tonight, Dr. Sahay.
Yeah. So good evening to all. Thank you for the introduction, and a good morning to Professor DeFranzo. Looking forward to the exciting evening ahead.
Thank you. And finally, we have an army man in our midst. This is Dr. Surendra Kumar, who's served in the Indian Army for more than 25 years. Well, he's the chairman of the Department of Endocrine at Sir Gangaram Hospital from New Delhi since 1999. He's been the honorary endocrinologist to the President of India and is also the president of the SARC Diabetes Association. He's always been a straight shooter. Well, Dr. Kumar, welcome tonight in our midst.
Thank you so much. Nice to share the dais, the so-called virtual dais, with Ralph and all the friends from India. Thank you very much, and we shall have hopefully great discussion now.
Absolutely. Well, and with that was a long introductions, but so many things to say about so much of our eminent faculty tonight. With that, let's roll into the academic part of this session. We're going to have the opening batsman tonight is going to be Dr. DeFranzo, of course. So Dr. DeFranzo, you have come a long way defining for us the triumvirate all the way to the ominous octet. I want to know from you, firstly, how did this conception come along? Was it a eureka moment that you thought of all of this? Has this something that has been an evolution, the conception, the crystallization? Give us the story and tell us about the future. Is there some more things that we don't know about that's all in the pipeline?
Great, thank you. So tonight, it's a little bit different format. Rather than giving a formal presentation, I was presented with a number of questions, which I'm going to try to address. Many years ago, it became very clear to me that there was no simple 1, 2, sort of 3 punch that was going to explain the pathophysiology of type 2 diabetes. I started with the triumvirate, but then it became very clear that there were many more pathophysiologic disturbances. And what I'd like to do is kind of give you a little bit of background and show you why the progression from the triumvirate, which was insulin resistance in liver, insulin resistance in muscle, and beta cell failure, had to evolve into the ominous octet. And then I'll update you as to where I think we stand with the ominous octet. First, I think everybody who's listening in understands that diabetes is a big problem. It's a big problem here in the United States. We have 37 million people, but in fact, if you look at the number of people with prediabetes, for every person with diabetes, there are 3 people with prediabetes. So this is going to continue to be a huge problem. But as big as a problem as is type 2 diabetes in the United States, you can see it's an even bigger problem in India, with 77 million Indians who have type 2 diabetes. In India is second only to China in terms of the prevalence of type 2 diabetes. So it's a big problem in our country. It's an even bigger problem in your country. And diabetes is associated with a markedly increased number of complications, eye, kidney, and nerve damage, which contribute to the morbidity. And then, of course, but what kills our patients with type 2 diabetes are the cardiovascular complications. So how are we doing in terms of glycemic control? And I am going to relate this all back to the ominous octet. So these are data in the United States, and I can assure you that they're very similar data that are occurring in your country. In fact, the numbers that I were able to see suggest that the level of glycemic control in India is actually even a little bit worse than in the United States. So the American and European Diabetes Association goal for treatment is an A1C less than 7. And you can see if you go back to the year 1999, we had about 50% of the people who had an A1C less than 7. That means 50% above 7. We did a little bit better in the early 2000s, but you can see we've kind of plateaued off. And we still have about half of the people in the United States who have an A1C that's above 7. And we know from many studies that this is associated with an increased incidence of microvascular complications. And if you take a look at the yellow curve at the top, how many people have an A1C less than 8, or what I would turn it around is how many people have an A1C above 8, which is totally unacceptable. It's about 25 to 30% of the people in the United States. And the data in India are, in fact, as bad as the data in the United States. So we have a long way to go, really, if we want to prevent these kind of complications. So why are we having such a problem? At the top of the list, I've put here the treat to fail approach. We put persons on drug A, and when they fail, we add drug B, and when they fail, we add drug C. And in fact, this is not a very effective way. And tonight we're going to talk about combination therapy, which is where I think we should be right from the beginning. We have physician inertia. They see the A1C, but they don't initiate a change in the therapeutic regimen. Patients, if they don't want to cooperate, and that's a big problem, will always defeat the doctor. Cost of medications can be very expensive, and that's another reason why combination therapy is a benefit to the patient. And then there's a very complex pathophysiology, as we have discussed earlier. And this has led to my Banting lecture in 2008, which is the ominous octet. And it's shown here. We know this disease starts with insulin resistance in the liver. The liver in diabetics overproduce glucose. This causes fasting hyperglycemia. The diabetic wakes up in the morning. They have their breakfast, lunch, and dinner. The carbohydrate needs to be taken up in the muscle, but the muscle's resistant to to insulin. This causes postprandial hyperglycemia. And then, of course, this is all aggravated by the progressive beta cell failure. So I call this the triumvirate in the Lilly lecture, but you can see in the Banting lecture, this evolved from the triumvirate to the ominous octet. So the gut is a giant endocrine organ. It secretes two incretin hormones, GLP-1 and GIP, and these two incretin hormones account for 70% of the insulin, which is secreted by the pancreatic beta cells. And we know that the pancreatic beta cells have become very resistant to GLP-1 and GIP. And of course, we have a number of injectable analogs that can overcome this GLP-1 resistance. At the level of the alpha cell, there's overproduction of glucagon, which drives hepatic glucose production. We also know that the fat cell is resistant to insulin. It's constantly breaking down the triglyceride, releasing FFA into the bloodstream. Elevated FFA impair insulin secretion and aggravate the insulin resistance in the liver and in the muscle. And then many years ago, we did a number of studies that demonstrated that the kidney threshold for spilling glucose, which is normally about 180, is markedly elevated in the diabetic. So the glucose, when you become hyperglycemic, instead of spilling out into the urine, is retained within the body. And then at the level of the brain and the hypothalamus, we know that there's marked resistance to a number of anorectic molecules, including GLP-1. This leads to weight gain. And when you gain weight, you become very insulin resistant in liver and muscle. So what's new? I'm going to add a couple of more pathophysiologic disturbances that you may not be familiar with. Number 9 is the decadent decouplet. So we know that in the resting state, only 1/3 of the muscle capillary bed is being perfused by insulin. And in URI, when we eat a meal and the insulin level goes up, it now dilates the remaining 2/3 of the capillary beds. So now more insulin, more glucose is now delivered to the muscle. And this is a very important physiologic response that maintains normal insulin sensitivity. So what goes wrong in the person with type 2 diabetes? The ability of insulin to dilate those remaining capillary beds is markedly impaired. And I refer to this as vascular insulin resistance, which goes with the muscle, the fat cell, and the liver insulin resistance. Number 10 that I've added now to the ominous octet is the noxious non-tuplet, and that's inflammation. And what we know is that there are a number of inflammatory pathways, the I-kappa beta, NF-kappa beta pathway, toll-like receptor pathway, and so forth. Many of you listening in may not be familiar with these pathways, but I'm certain that our illustrious panel is very familiar with them. And these pathways are all overactivated, and they interfere with insulin action in the muscle. Now, I know we'll hear more from Dr. Chowdhury, but I know someone is going to ask me about the microbiome. The data in, I would say, in the animal models have clearly demonstrated that an alteration in the microbiome plays a very important role in the development not only of obesity but type 2 diabetes. At the present time, I remain a little bit agnostic about the microbiome in terms of human studies. So I'm sure that this will be a point of discussion as we go through today's presentation. So now, if you understand that there are 8 or maybe 10 or even more pathophysiologic disturbances, it should be very, very clear that we're going to require multiple drugs in combination right from the beginning to correct these multiple pathophysiologic defects. And that's what we're going to be here tonight to talk about in great detail. And when we decide what drugs we are going to use to treat our diabetic patients in combination, we should be picking drugs that correct known pathogenic abnormalities and not simply drugs that lower the A1C but don't maintain the reduction in A1C. And we need to start very early in the natural history of type 2 diabetes if this progressive beta cell failure is going to be prevented. So that's kind of a brief update on the ominous octet and what I think we need to add to it. And with emphasis on the point that if you have 8 or 9 or 10 pathophysiologic abnormalities, I mean, it's pretty clear. No one drug's going to correct 10 problems. You need to start right from the beginning. And I have to say that India is way ahead of the curve in terms of developing drugs for combination therapy compared to the United States. We're kind of a late comer to this therapeutic approach.
Thank you so much, Dr. DeFranzo. That was very, very succinct and clear regarding the whole understanding of the pathophysiology and what we're going to also see more talk about in the future also as well. Coming then, this is the evolution of the pathophysiology. How about evolution of management? Like when I was doing fellowship, we were starting with, when I was in the US, and this is like maybe 15 to 20 years ago, we were maximizing metformin, then maximizing glimepiride and maximizing pioglitazone, after which we added on insulin. From that point of time to today, we are talking about starting a fixed dose combination of 3 medications all together early in diabetes. What is the rationale? And when you say the US has been a little slow in adopting this practice, why would you feel that has happened?
Yeah. Okay, great. Well, that's a lead in. And, as I said earlier, these questions were presented to me earlier, so I was able to put together a few slides. I'm actually happy that you mentioned pioglitazone. It's the one of the drugs that I'm not going to talk about, but I think everybody who knows me know that I'm a big advocate of pioglitazone. We're going to talk about a particular type of triple combination tonight, but maybe you ought to consider the quadruple tablet where you add pioglitazone to the 3 that we're going to talk about. So maybe if you can get my screen back up again, I'm not sure how to do that. There are a series of slides that will address this question. You'll have to probably lead me through this again. Hit share screen. All right. So what are the drugs that we know work or don't work? So I'm going to take you back to the United Kingdom prospective diabetes study, which is a study carried out by Dr. Robert Turner many years ago. And he was a strong believer that you could put people on a single oral agent, and if you did, the A1C would come down and stay down. And you can see that hypothesis turned out not to be correct. So there were over 4,000 people in this study. They were newly diagnosed. They start with an A1C of 7. 1/3 of the group got on conventional therapy. That's the yellow line. This is diet and exercise. And you can see, in fact, that this was not a very effective therapy. That he then compared that to 2 other groups. And these were the only 2 medications that were available when he started these studies back in the 1980s. Sulfonylureas, this is glyburide, glibenclamide. They work on the beta cell, and they do initially drop the A1C, but you can see that after the first year, the A1C rose progressively. Metformin, which is a drug which I brought to the United States in 1995, works on the liver, suppresses hepatic glucose production, A1C goes down, and it's unfortunately does not stay down because metformin really does not work as an insulin sensitizer in muscle, and it doesn't affect beta cell function. And so what Dr. Turner said is that, look, my hypothesis is not correct. You can't put people on a single oral agent and drop the A1C and keep it down. And although this study is mostly known for being the first study that showed that this difference in A1C of 1% decreased eye, kidney, and nerve complications by 37%, it also told us that monotherapy is not going to work in controlling our diabetic patients. So yes, it taught us that good control does decrease eye, kidney, and nerve complications, but it also told us we needed to start to think about combination therapy. But the fact it's taken us 30 years to learn what Dr. Turner said. Now, most recently, we've had the GRADE study. It's called the Glycemic Reduction Approaches in Diabetes, a Comparative Effective Study. And this was carried out by the National Institutes of Health. And the question that they asked, look, if you are a metformin failure and you have an A1C above 7.5, what is the best drug to add to metformin? So they added a sulfonylurea, glimepiride. Another group of people, they added sitagliptin. Another group of people, they added glargine insulin. In the third group, they added a GLP-1 receptor, liraglutide. And yes, there was an initial decline, as Dr. Turner showed in the first year. But then look at this progressive rise in A1C. So this now study carried out 30 years later. What have we learned? We've learned that monotherapy does not work, that you're going to have to use drugs in combination. So I take you back to the original metformin studies that I carried out that got metformin approved in the US by the Food.
Everyone.
Hello? Yes. So here's the baseline A1C, and placebo had no effect on dropping the A1C, but you can see with metformin, a very nice drop in A1C. But as we learned from the UK PDS, this A1C doesn't stay down. Same thing if you add metformin to glyburide, placebo does nothing. Metformin causes a nice drop in the A1C. But again, this A1C drop is not persistent. DPP-4 inhibitors, a very safe and effective drug in lowering the A1C. These are data with saxagliptin, and you can see you can add the drug to drug-naive patients. You could add it to people who are on sulfonylureas, metformin, or TZDs. And if you start with an A1C of 8, you'll drop the A1C by about 0.7 to 0.8. And these are the early sitagliptin data, which is part of the triple combination tablet that we're going to talk about today. In this study, if there are 2 doses of sitagliptin, 100 and 200, and you can see very nice drops in A1C, about 0.8 to 0.9. And these drugs have a significant effect on the beta cell. This shows you the increment in HOMA beta with sitagliptin, and you see a nice increase in beta cell function with both doses of sitagliptin. And if we come back to the ominous octet, you can see that there are 4 abnormalities that are part of the ominous octet that are benefited by the DPP-4 inhibitors. First, they increase GLP-1. The GLP-1, as I just showed you, works on the beta cell to increase insulin secretion. Data that I didn't show you, they also inhibit glucagon, and the rise in insulin and drop in glucagon suppress hepatic glucose production. What about the SGLT2 inhibitors? Again, another important component of the triple therapy that we're talking about tonight. So for those of you who know my background, I invented this class of drugs, but unfortunately didn't patent it, a major mistake. These drugs correct a novel pathophysiologic defect at the level of the kidney. That elevated glucose reabsorption is blocked, and so the glucose now appears in the urine. As the glucose concentration comes down in the plasma, we reverse glucotoxicity, we improve insulin sensitivity in muscle, we improve beta cell function, we have a nice reduction in the A1C. Because you lose calories in the urine, you see significant weight loss, and you can combine the SGLT2 inhibitor with any of the other anti-diabetic agents that are currently on the market. Because we block glucose as well as sodium absorption in the kidney, we get a nice drop in systolic and diastolic blood pressure, and this class of drugs is quite safe with no hypoglycemia. So we're going to see improvement in glycemic control. We're going to correct a number of cardiovascular risk factors, so you might expect cardiovascular benefit. I'll come back to that in a second. So how do these drugs work? The primary effect is on the kidney. And when you enhance glucose excretion and the glucose concentration comes down, you can see in the ominous octet, we get an improvement in insulin sensitivity and beta cell function. So we correct 3 of the abnormalities of the ominous octet. But even more impressively is what the SGLT2 inhibitors do in terms of cardiovascular and renal benefit. So these are the three major drugs that we have in the US. We have two other ones, but I'm just going to focus on dapagliflozin. These are the data from the DECLARE study. Canagliflozin, which I know is not very popular in India, the CANVAS study, and empagliflozin from the EMPA-REG study. If we look at the MACE endpoint, which is major adverse cardiovascular events, this is non-fatal MI, non-fatal stroke, and cardiovascular death. The white line is a hazard ratio of 1, all the points to the left, meaning a significant benefit. There's some controversy about cardiovascular death, but in my opinion, the major difference between these three drugs has to do with the patient population. In the EMPA-REG outcome study, 100% of the people had a previous cardiovascular event. So here you see the biggest effect with empagliflozin. With the DECLARE study with dapagliflozin, this was the least sick population, the least benefit. But as we come down, you see very similar effect to protect you from myocardial infarction. We still don't understand, since these drugs drop the blood pressure, why we don't see a benefit in non-fatal stroke. Hospitalization for heart failure hazard ratio is 0.7, a dramatic effect, and prevention of end-stage renal disease hazard ratio 0.55. So this class of drugs has very powerful effects on the heart and on the kidney. Now, in the United States, the one triple combination therapy that we have is Chowdhury, and this now shows you the A1C data that is generated from this study. You can see empagliflozin dropping the A1C by 0.6. That's the 25 milligram dose, very similar to the 10 milligram dose. Linagliptin, DPP4 inhibitor, dropping you by 0.7. And when we put the linagliptin and the empagliflozin together with metformin, you can see EMPA-10, EMPA-25, Lina 5, metformin 1500. Look at these very nice drops in A1C. So what we're going to talk about today, as the discussion goes on, is UDAPA trio, which is metformin, dapagliflozin, and sitagliptin. And I think I've provided you with enough of the clinical data to show you that this is going to be a very, very effective combination. Okay, so I think I'm going to turn it back to our moderator at this point.
Thank you, Dr. DeFranzo. That was a good introduction to our next speaker of tonight. Our next question goes out to Dr. Jayshree Gopal. So Dr. Jayshree, question for you is, we've now, so many of the drugs for diabetes now have gone off patent. We are seeing a deluge, literally a deluge of all of these off-patent drugs entering India. What is the Indian evidence behind this? USV, our sponsors for tonight, also UDAPA trio, as Dr. DeFranzo has just spoken about. They make such a triple combination themselves. Please give us some of the Indian evidence available.
Good evening. While I'm just waiting for the slides to come up, this is the data with the triple combination from India. Yeah, good evening, and it's a pleasure to be here. I think, like Dr. DeFranzo mentioned, India has been way ahead of the curve in terms of using fixed dose combinations. We've had the sulfonylurea metformin combination for a long time, and then we had sulfonylurea metformin voglibose combination, and then we had sulfonylurea metformin pioglitazone, and now the latest one to enter the market, of course, is the combination of SGLT2, DPP4, and metformin combinations. And
Somat, please unshare the screen of Dr. DeFranzo.
Please share, Dr. Jayshree.
yeah, I don't have the slide, sorry.
We are
Somebody
sharing,
has to.
ma'am.
1 minute.
Give us
for
a
the
second.
unsharing.
And just to point out that the triple combination we have, most of the companies come out with a combination of DAPA 10, SITA 100, and metformin either 500 or 1000. Most initial ones only came out with 1000 mg, and now we also have the 500 mg, but the 10 and the 100 pretty much stays fixed in the triple combination. So this was an initial study done to evaluate the efficacy and safety of the fixed dose combination. There is very, very limited data available in this. And this has been shared by the company, which I'm sharing here. So these were people who were inadequately controlled, people with type 2 diabetes, inadequately controlled on metformin monotherapy. And they were randomized, about 137 people were randomized to the fixed dose combination of the DAPA-SITA metformin. And another equal number were randomized to the dual combination of SITA and metformin. And sorry, can we just go back to the previous slide? I just wanted to point out that a large number of people actually completed the 4-month trial. So the number of dropouts was very limited in both the groups. Thank you. Next slide. So you can look at the change in the HbA1c as expected and similar to the data like what Dr. DeFranzo showed. The triple FTC had a significant drop in HbA1c, minus 1.72, as compared to the dual FTC, the DPP-4 inhibitor metformin combination, which only had a drop of about 1. And you can see the same represented in graph. Next slide, please. So this was at the end of 4 months. If you look at the actual fasting and postprandial glucose, again, as expected, the triple FTC dropped the fasting by about 35 and the postprandial by about 77 milligram per DL. The dual FTC correspondingly about almost half this level, drop in fasting of 20 and a drop in postprandial of up to 50. And if you look at the number of people who achieved an HbA1c of less than 7.5, nearly 55% in the triple FTC group as compared to only about 30% in the dual FTC group. So at least in this preliminary data, it looks like the triple combination is superior to that of the dual FTC. And this is not surprising. I don't think this data is surprising. We all know that DPP SGLT2 inhibitors work very well, and the combination in fact works very well, the DPP4 and SGLT2 inhibitors. Next slide, please. This was a phase 3 multicentric randomized trial, and just to the same data showing that there was no difference between the two groups in terms of safety. Can we just go on to the last trial? This is the MESIDA trial. The last slide, please. Also, the other secondary efficacy endpoints, because we are also more interested in things like the mean body weight. You can see that the change in the mean HbA1c in the triple FTC was 1.5 versus 1.02 in the MESIDA trial. The mean fasting glucose, again, a significant drop of 19 versus 3, and postprandial glucose of 50 versus 13. And the mean body weight, not very significant, minus 1.31 versus 1.2 between the two groups. What I have noticed is that we have to keep in mind that the HbA1c drops significantly. So these are all people who are achieving a good glycemic control with maybe a 1 to 2 kilograms reduction in weight, but with a normalization of HbA1c. So this has to be taken in that context. So the glycemic improvement occurs along with a little bit of weight reduction. And again, this study also proved that the FTC was superior to a combination of metformin and sitagliptin in terms of the improvement in glycemic parameters. Next slide, please. And this is some data from one of the electronic health records in India. What was the baseline HbA1c at time of initiation of triple FTC? And it was about evenly distributed. Less than 7% also. About 17% of people, physicians chose the triple combination for various reasons, but most of them had a HbA1c between 7 to 8, 8 to 9, and you can see even a third of about more than 9%. The vast majority of people in whom triple FTC was used was as a second line therapy. And in about 6% of people, it was preferred as the first line therapy. So in drug naive patients, it was opted for as the first line therapy in about 6% of patients. So this is the data that we have available. This is real world data. And of course, the commonly co-prescribed medications that you can see on the right hand side of the slide is as expected. People were on all the other combinations, metformin, insulin, the other triple combinations, like I mentioned earlier, that we have the metformin SU, AGIs, the metformin SU, pioglitazone, and other combinations. So this is sort of the background on which we have the data with the triple FTC. Now, the data, which has not been projected here, but I'm just going to talk about the few patients that I've used the triple FTC on, is the change in the creatinine level. The change in the creatinine is as we would expect for people who get started on SGLT2 inhibitor. Longer the duration of diabetes, a little bit lower eGFR to begin with. There is about a 5% drop as expected, but nothing more than what we would expect with an initiation of an SGLT2 inhibitor. And we've not really noticed any significant adverse effects, at least with this few months of use since this triple combination has been on the market. With that, I will stop and thank USP for this opportunity, and always a pleasure to listen to Dr. DeFranzo. Thank you and good night.
Thank you so much, Dr. Jayshree. We're going to bring in all our panelists for their opinions tonight about the useful of this particular FDC in their clinical practice. Let's start with Dr. Surendra Kumar tonight. So Dr. Kumar, what is your opinion about this FDC? Does truly one size fit all? What kind of patient profiles do you use this combination in?
Very much. First, like to stress,
Dr. Surendra Kumar?
What we have learnt in the last couple of years is controlling glucose is one aspect. How to control is second aspect, which is more important. With the help of insulin, you can bring down the glucose to whatever level, but by producing weight gain and by producing hypoglycemia, risk is there. So the drugs which are disease modifying, like metformin, SGLT2 inhibitor and DPP4 inhibitor, as well as pioglitazone, they have come in the category of disease modifying agents. Their advantage must be given to every patient as far as possible. And secondly, since disease is a multifactorial disease, so we must kill all the factors together: insulin resistance, creatine defect, as well as the incretin defect, and all, if possible, in one stroke. And for this we need a multi-barrel gun, and this barrel of this gun, which has got 3 barrels, will kill resistance, creatine defect, as well as the incretin improvement is going to be there. So every patient, as far as possible, right from the beginning, should be given advantage of this triple drug therapy.
So great. We have from Dr. Kumar that every patient deserves this multi-barrel gun of therapy. Dr. Bantwal, do you see any disadvantages in starting off all of this early hit hard kind of combination? Where do you use it in your practice, and any disadvantages in your opinion?
See, as Dr. Surendra Kumar has told, it's a great molecule. As I rightly told, we must try to use as much as possible in all of the patients. But then the disadvantages, if at all, is suppose somebody has a genital mycotic infection which is not getting controlled in spite of better genital hygienes, all these things. That's one place where I have a trouble. The other patients could be, say patient is having a structural genitourinary tract problem. So you have a blockage or something. These are another group of patients. And maybe patients with autonomic neuropathy having a postural drop where I'm a little bit concerned, and maybe just don't use it before surgery. Stop it at least 24 to 72 hours prior to that. I think these are some places where probably I will think over to start. Otherwise, great molecule. You must use it in as much as possible in all the patients, because it not only brings down glycemic control, but it has a cardio-renal metabolic benefit. So, and in a single molecule, in a single triple drug combination as a single drug, at least really works.
Right. Thank you, Dr. Bantwal, for highlighting where we need to be a little more careful. Dr. Chandalia, here with me here today. Dr. Chandalia, you have seen the evolution of diabetes management through these years, from where we started off with one drug and then went on. And now we're talking about hitting so early, so hard with 3 drugs together. What is your experience with this kind of change?
Yeah. I think this drug combination is unique, because first time we have combination of 3 drugs which do not produce much hypoglycemia. So this is the most important feature which really makes this the most welcome combination we can have. Now, should everyone receive? No, of course. So the majority of patients, at least long-standing type 2 diabetics, will end up with these 3 drugs. So this combination will be required with many of them as they go along. However, let me let me tell you a few exceptions that one would make. For example, right at the time of diagnosis of type 2 diabetes, some of them are controlled very well on lifestyle and metformin. And then there are others who can be controlled by addition of DPP-4 inhibitor. And of course, a vast number which they as go along, we require the combination of three because we know that there is a gradual beta cell failure in type 2 diabetes. And many of the drugs fail as we go along in 4 years or so, more evidence again showed today by Dr. DeFranzo. So I would say, except some situations, and of course we have to know that if there is renal problem, it is a very good drug, but if eGFR is less than 30%, then I think 30 ml, then it is contraindicated. So this is very important. And very importantly, dapagliflozin, which is a very important constituent of this triple combination, has a few contraindications. For example, in any emergencies, you cannot use this drug at all because in emergency, two drugs which are immediately reviewed is metformin and of course also the gliflozins, so SGLT2 inhibitors. So there are some exceptions like this. But apart from that, a good majority, and especially I must say type 2 diabetic, often not controlled after first few years of type 2 diabetes, very typical profile I'll give you. After first 4 or 5 years of type 2 diabetes, it gets difficult to control. Is that this is triple drug is the best offer for that. If by that time there is some evidence of multiple cardiovascular risk factors, or if there is a cardiovascular disease or there is very early renal disease, microalbuminuria, it is clearly indicated. In fact, it will be a sort of negligence not to introduce dapagliflozin, which will be the third drug. So there, of course, it will be a valuable drug. As a matter of fact, not giving is doing a disservice to the patient. So I think those situations, I must tell you that I also take more than 10 years of type 2 diabetes itself a very important cardiovascular risk factor. Even if you're not evaluated patients in detail and apparently everything seems all right, yet I take duration and there is evidence that although ab initio type 2 diabetes is not, we don't think now is a cardiovascular risk equivalent, but there is evidence that 5 years on it starts getting a little difficult and 10 years on, again, it is a cardiovascular risk factor. So duration of type 2 diabetes, and that's the time where probably failure of the dual combination will be already there. So it coincides. So I think that is the situation. So a vast majority of type 2 diabetes will be on it, except for emergency situation. And of course, when and the eGFR falls below 30, then metformin also is interdicted, as well as dapagliflozin. And therefore, of course, you know the treatment is very different. But you must know that this is paradoxical situation with mild renal involvement to the degree of eGFR falling to 30, it is an ACE drug. Because you see, and there I would put one caveat that I will use the combination where the metformin is 500 milligram. When you go near 30, eGFR or 35. I must also tell the clinicians that when you do this kind of treatment, remember all the recommendations are based on what we call stable eGFR. You sometimes don't realize that word is there. And in clinical situation, it will not be stable. So I want you to be very cautious when you use this because, a little bit of dehydration or some insult to the kidneys, you see suddenly eGFR can drop. So you have to see that the patient is stable, eGFR is more than 30, then you can introduce this without any difficulty, in fact, some benefits for sure. And in fact, the benefit there is of the magnitude of 30 to 45% with this group of drugs. So this is really far more than even cardiovascular protection, which, the composite factor was, the reduction was about 15%. And this is true of this whole SGLT2 group inhibitors.
Thank you, Dr. Chandalia. Extreme words of wisdom, as always, from Dr. Chandalia's many, many years of practice. Dr. Chowdhury, for you then, again, would you say early in the course of diabetes, late in the course of diabetes, and when you do you start out single drug, then combine one by one, fast, maybe fast, and then combine them all together? Or do you ever give the drug as a get-go for high diabetes right from the start?
Right, thank you. So, when we treat diabetes, and let's concentrate on type 2 right now, we have different objectives in mind. One is to get the glucoses under control. That still remains important. We need to remember, despite our penchant in looking for treatment that also provides organ protection, we also need to get the glucoses under control. Second is to provide organ protection, and today at least we have good evidence for protection of the kidneys and also possibly of the heart. We would also like to look at something that protects the liver. That's another important comorbidity that we see in type 2 diabetes. The third issue that we would like to have incorporated is something that may modify the course of the disease. And in this context, at least from the Verify study, it suggests that combination of, beyond metformin, combination with a gliptin may help to modify the course of the disease as well. So in this context, a large proportion of our patients, even as they come for the first time to us, would fulfill the criteria or the need to get a triple drug combination, and especially a combination that does not cause hypoglycemia, which is weight neutral. And clearly this particular combination that we are talking of this evening fulfill those criteria. Later on in the course of the disease, also they will be useful. And I am clearly, I'll be very sort of eager to use this sort of combination, especially where the A1C of the patient is at least 1.5 percentage points off the target, maybe 1.5 to 2 even early on in the course of the disease. We'll be happy to use this triple drug combination, especially because it will not lead to, it's very, very unlikely to lead to hypoglycemia. I'll stop here.
Thank you. Thank you so much, Dr. Chowdhury, for that input. Dr. Sahay, for you, tell us, with this FDC in older patients, what would you suggest we do, let's say more than age 70, 65, 70, thereon? What is your advice?
Yeah, so I think as has been highlighted by Professor DeFranzo, the pathophysiological abnormalities which are addressed by this combination, I think it is a very useful combination. Now, coming to the older individuals also, because of the fact that this has a very low risk of hypoglycemia, it serves as a useful combination even in older individuals. And this has been proven, although this combination has probably not been studied adequately in older people. We still need more data on that, but individually these agents have been looked at in older people. Metformin has been studied, combination of metformin with the gliptin has been studied earlier, and even say dapagliflozin has been studied in older population, and they have been shown to be good in older people also. So I think putting that together, and the fact that it has a low risk of hypoglycemia, it would be a useful combination. And what we see is that majority of our population of diabetics are having HbA1c of more than 8.5, as Dr. Shubhankar was highlighting, that he would look at this combination when the HbA1c is more than 1.5 to 2%, so above the target. And so many of our diabetic patients fit into that population and that category. And I think over the years, what has happened is that we are slowly evolving to use these medications earlier than the sulfonylureas. We are going to keep them a little lower down in the list. They still have a place, but they would come a little lower down after we use this combination. And in those who still don't achieve the target HbA1c, then probably, there's a place for this.
Right. Thank you so much. Dr. Jayshree, for you, now that we have so many, you presented to us the Indian evidence. How do you sift through the various different triple drug combos? I mean, any pointers on how we should actually, let's say, translate all the Indian evidence into clinical practice while choosing these triple drug combos in particular?
Yeah, thanks, Dr. Piya. I think the verified trial really sort of helps us strengthen our what can I say? I mean, like I said, in India, we've always been using these sort of double combinations, fixed dose combinations. The verified trial showed that we were on the right path. So soon after diagnosis of diabetes, initiating a double combination itself, gave you the good sort of impact at the end of 5 years. And I'm sure this FTC data hopefully will give us even better data and a bit further longer out. So how do we choose? Again, like all the speakers have said, we need a molecule which does not cause weight gain, which is well tolerated, which does not cause hypoglycemia. So obviously, among the currently available molecules, I think this particular combination is the one that is going to stand out. And I think it just becomes easier to choose a FTC which has this to begin with. And like Dr. Sahay and said, and all the other speakers have said, the other older molecules move further down the list. We do keep in mind that some of the other molecules have significant benefits. And like Dr. DeFranzo said, maybe there'll be other even more super powerful combinations. It always reminds me of like Superman or something, all of these medicines which are coming with these fantastic combinations coming to attack diabetes. But yeah, maybe we'll have even better combinations. But I don't think there's any doubt that this type of triple combination, because of its safety and the fact that you're going to achieve all that we want to achieve in the management of type 2 diabetes, should stand high up in the diabetic armamentarium.
Thank you, Dr. Jayshree. Dr. DeFranzo, we're coming back to you. Give us your final verdict now on the use of this combination and the change in diabetes management that we have learned now, right from managing hyperglycemia to the overall cardio-metabolic care approach. What is your comment also on the Indian data is what we'd like to hear. If we could go to the slides back again for Dr. DeFranzo.
Yeah, I'm afraid to touch my screen here. Yeah, I don't know if you can get my slides up. So you'll have to lead me through this. Share screen again. And this always happens. You're going to have to help me. Okay. Sorry about this, but let me just get to. Okay. I think you can see this, although it may not be full screen. Can you see this?
Yes.
Okay, I'm not going to touch anything because I'm happy with it, okay? So I like to sort of introduce this part with, I think that this is a pretty terrifying overview of what's going on in diabetes in the United States. So I think it's important that you see here in the white with the red background, every 24 hours, and believe me, this is exactly what's going on in India. There are 4,000 new cases. Now, remember, you have 3 times as many diabetics in India as we do here in the United States. So you can make that 12,000. We have 810 deaths every day from diabetes. Multiply that by 3, 2,400 in India. 230 amputations, multiply it by 3, over 600. 120 cases of kidney failure, 55 people going blind. Multiply those numbers by 3. And you can see that this is a devastating disease and with very serious complications, amputations, blindness, dialysis, and then the ultimate complication, death, okay? So I'm just going to skip ahead, and I'm just going to use this one slide because we've focused a lot on glucose control, but you need to remember there are at least 4 major pillars of diabetes management. Glycemic management, very, very important. And finally, we've had a change in the ADA guidelines, which originally said, you should start with metformin. But now with the data with the SGLT2 inhibitors, the guidelines have now changed, and the 2023 standards of care clearly point out that if you have someone with chronic renal disease, that you should be initiating therapy with an SGLT2 inhibitor, or if you have someone with heart failure, the initial drug on board should be an SGLT2 inhibitor. And of course, what we're talking about today is a triple combination that does have the SGLT2 inhibitor there. But with the important caveat that was brought up in the previous, one of the previous speakers, that when the GFR is less than 30, of course, metformin becomes contraindicated. So although we would like the people to be on the SGLT2 inhibitor, unfortunately, you're not going to be able to use this triple combination therapy. If you have underlying atherosclerotic cardiovascular disease as the primary, as a major complication of the diabetic patient, the recommendation is the first drug on board should be a GLP-1 receptor agonist. So again, these are specific situations in which the triple therapy drug may not be the first one of choice, but we're talking about 15 or 20% of our diabetic population who has either renal disease or cardiovascular disease. And the other 80%, I would, be in favor of starting with the triple therapy. Blood pressure management, very, very important. The new American Diabetes EASD goals of therapy say that your blood pressure should be 130/80. And this is in large part from the SPRINT trial, but a number of other trials. And of course, the SGLT2 inhibitors as part of this triple combination have been shown to decrease systolic blood pressure about 6 or 7, diastolic 1 to 2. But that's in people who are normotensive. If you look at the data, if you look at people who are hypertensive, you got much bigger drops in blood pressure. Lipid management is critical. So the characteristic diabetic dyslipidemia is small dense LDL, high triglycerides, and low HDL. So this combination that we're talking about is lipid neutral. So an additional aspect of the therapy is going to be to focus on the LDL cholesterol, which we haven't talked about. The LDL goals really kind of depend upon the number of risk factors that are present in our diabetics. So the ADA goal says if you have diabetes with no risk factor, you can use a moderate intensity statin. I don't have any of those people in my practice, quite frankly. All of my diabetics have one or more risk factor. So they're all going to be on a high intensity statin. And in people who have multiple risk factors or underlying atherosclerotic cardiovascular disease, the goal is to get the LDL less than 70. So in addition to a high intensity statin, you should be thinking about ezetimibe and maybe even a PCSK9 inhibitor. And then in people with cardiovascular or kidney disease, clearly, as I pointed out to you, the SGLT2 inhibitors are drugs that we should be considering along with the GLP-1 receptor agonist. And we haven't talked much about antiplatelet therapy, but in people who have risk factors in diabetes, low-dose aspirin is advocated. If they've had a previous cardiovascular event, then we are talking about dual antiplatelet therapy. So again, the triple therapy is, I think, a wonderful drug for glycemic management. I do believe that the SGLT2 inhibitor will provide you with cardiovascular and renal protection, but we need to pay meticulous attention to the other cardiovascular risk factors, particularly blood pressure, lipids, and the prothrombotic state. So I will stop here and open it up to further discussion from our panel members.
Thank you. Thank you, Dr. DeFranzo. That again gives us the pillars of diabetes management. And we're going to then get on to our panelists here, run through a quick set of questions with them. We're opening this panel with Dr. Surendra Kumar again. Dr. Surendra Kumar, though we've discussed it again, just to re-emphasize, what should be the eGFR cutoff to begin this combination?
Somnath, can you just stop the screen share? Tech team, can you just stop the screen?
Says that up to 20 ml GFR you can use it, but be careful because in some of the studies up to 15 ml GFR has been studied, and the only word of caution is acute tubular necrosis is the worry. So hydration is important. Otherwise, from safety point of view, 30 up to 30 ml safety one can use, but as far as the Kidney International is concerned, they say up to 20 ml GFR for renal advantage you can continue to use. So 60, 30 and 20. Once it's over 30, still there are chances of complication are less, but between 30 and 20 you have to be very careful, mainly from the acute tubular necrosis. So hydration becomes extremely important.
Have you used it for a 20 GFR yourself, Dr. Kumar?
No.
Not yet. Okay. Dr. DeFranzo, do you use it for a 20 GFR?
No, I think the problem is the metformin, not the SGLT2 inhibitor. So if the GFR is 30 ml or less, there's a contraindication to starting the metformin because of the concern for lactic acidosis. And remember, a not uncommon side effect with metformin is nausea, vomiting. And there, as pointed out, you can get a little bit volume contracted. With the SGLT2 inhibitors, I personally believe, even though this is not what's in the sort of the package insert, that people, if you're just on an SGLT2 inhibitor, the SGLT2 inhibitor should be maintained up to the time you go on to dialysis. Now, of course, you can't do that with the triple combination therapy because the metformin is a contraindication. But at that point, you're going to have to get the person off the triple therapy. They should be maintained on the SGLT2 inhibitors. Each one has a little bit of a different cut point, whether it's 25 or 30. But quite frankly, in all of the studies, about 5 to 10% of the people got in had GFRs less than 20, and they benefited equally as the people who had GFRs above 20. So although it would be a somewhat off-label use of the drug, I keep all of my patients on the SGLT2 inhibitor up to the time they go on to dialysis.
Okay, that's a great point there. SGLT2 inhibitors, the reason to remove this would be due to the metformin. Dr. Bantwal, for you, what are special education points that you would emphasize to your patient while using this combination?
Yeah, like I told you previously, one of the most important side effects is genital mycotic infection. So I always tell them about genital hygiene to be maintained, drink plenty of water. And in spite of this, if they get a genital mycotic infection, a local candidial cream, and if it still doesn't subside, I actually tell them to take fluconazole, 1 or 2 tablets for 2-3 days, and maybe then weekly once for 4 weeks. This is my regimen. Actually, I'm following it for genital mycotic infection.
All right.
The second thing, as I told you, this is one very important point. And secondly, like an ACE or an ARB, suppose somebody develops a diarrhea or a vomiting, you stop this drug temporarily because it can produce AKI. So that's another important thing. Thirdly, now it's a triple drug combination. The DPP4 inhibitors are known to produce skin infections, skin lesions. So if you find any skin lesions, many times they go to the dermatologist, but in fact, this could be the reason. You stop this, the DPP4 component, actually they become better, but not overnight. It may take approximately a month to become better. Uncommonly, if you get an angineurotic edema, so you'll have to be careful. You just tell them about this. Once again, the DPP4 component sometimes can produce. We see at least once in a year like this. And then rarely, of course, we are not come across, the DPP4 component sometimes can produce arthritis, which is not going at all. We think it's all vitamin D deficiency. We did a rheumatoid factor and they're all negative. And then probably it's because of this. That's another education. I mean, we'll have to keep telling them about this. And finally, if you have recurrent UTI because of urinary tract infection, because of a structural defect, I think you must not use this drug. That's another thing which we must tell them. And patients with autonomic neuropathy, which I highlighted previously, that if they're having a postural drop and all, you be cautious when you use this drug. And of course, we have already told, Dr. DeFranzo has told many times, if it is less than GFR, less than 30, we cannot use it. It's a metformin combination. And one more thing which I want to tell, this is not in general, this is to physicians and all. If you have an HbA1c more than 12% or so, start with insulin, bring it down, and then maybe use this drug. Because the euglycemic, the so-called euglycemic ketosis, acidosis happened in patients who had very high levels. So because they have become insulinopenic now, it could be glucotoxicity itself. The increase in glucagon can happen not sufficient by the DPP-4, which can actually reduce the glucagon. So it could tip in favor of a DKA. So in these type of patients, once again, I think we have to be a little bit careful. Control with insulin, perhaps, bring it down, and then use this triple recombination. So that will be my advice.
Right, that was a very comprehensive list you gave us. Dr. DeFranzo, do you see euglycemic DKA in practice?
No. This is one of the most overemphasized things known to mankind. So we wrote a very nice review article on this. The incidence in type 2 diabetic patients of euglycemic DKA is 0.2 per 1,000 patient treatment years. Now, of course, you need to be cognizant, as was pointed out by Dr. Ballani, of the potential patients. So I wouldn't be starting this drug in someone who has an A1C above 10. So if you, and of course, people who are on insulin, this is another issue. And so there are certain situations in which I think you have to be careful about the DKA problem. But I would say it is so uncommon that this should not be a reason not to be using drugs that have SGLT2 inhibitor part of them.
All right. Thank you for that input. Dr. Chandalia, for you, can this be used alongside insulin? And let's say if you have a failure of this FDC, do you move on to insulin immediately? Do you add more or other orals in your practice? How do you proceed?
First of all, if there is failure of this triple combination, I think only effective drug remaining then is sulfonylurea, and I would use either gliclazide or glimepiride. And of course, I prefer gliclazide in divided doses, the plain gliclazide divided doses, because it's more effective, and small doses of that does not cause much hypoglycemia. Now, coming to using this with insulin therapy, when we undertake insulin therapy, I always emphasize that sensitizing a type 2 diabetic patient to insulin is the key to success of insulin therapy. So unless you use a sensitizer in type 2 diabetic, the insulin dose is going to be extremely high and the response will be very poor. So when I use even a very effective basal bolus insulin therapy, even then, very difficult to control type 2 diabetics, 20 years standing. See, there we undertake sensitization with drugs. And what are the drugs? Metformin is, of course, a known sensitizer. But remember the DPP-4 inhibitors as well as SGLT2 inhibitors definitely show a reduction in insulin dose. And the reduction in insulin dose indirectly does mean there is sensitizing effect. And once the dose is reduced and divided into several parts, it is key to avoiding hypoglycemia. So a successful insulin therapy in type 2, thousands of patients that I treat, see, I don't remember anyone which we did not use an oral agent with it. Now, can you use this triple combination? Yes, with whatever caveats I already talked about. If those are not there, I would use this as a very effective, one pill in addition to the complex insulin therapies.
Dr. DeFranzo, do you feel insulin initiation has gotten pushed out so far due to all of these various great oral drugs that we have available now?
Yeah, well, I'm going to take a very different approach to this, okay? So I'm sorry to disagree with the previous speaker, but we have conclusively shown that metformin is not an insulin sensitizing drug. Metformin gets into cells through the organic cation transporter, and the organic cation transporter doesn't exist in muscle. And, you know, we did all of these data for the Food and Drug Administration, and that they have it all. And we've had multiple publications. Metformin's mechanism of action is on the liver to inhibit gluconeogenesis. But to come back as to when, the only true insulin sensitizer is pioglitazone. We've also looked at DPP-4 inhibitors. They are definitely not insulin sensitizing drugs. They may kick out a little bit of insulin or lower glucagon, and thereby you decrease the insulin dose, but they definitely are not insulin sensitizers. Now, when you have people who are truly poorly controlled with very, very high A1Cs, you know, in the 9 to 10 or above range, there are two choices, I believe. One we've discussed, that's a, you know, mixed split insulin regimen. That's kind of the standard regimen. But, you know, we've done two big head-to-head studies, including the Qatar study. And in the Qatar study, if you take people who have long-standing diabetes, 15 years, A1C, mean A1C 12.2, we compared a GLP-1 receptor agonist with pioglitazone with basal bolus insulin. And the GLP-1 receptor agonist with pioglitazone completely destroyed basal bolus insulin. So I'm not a believer that if you are poorly controlled, that you need to go to basal bolus insulin, although that's the standard approach. I think a more effective approach is a GLP-1 receptor agonist with pioglitazone, and that combination is also going to give you cardiovascular protection, which most of these people are at high risk. So I have a somewhat different approach to that particular patient.
All right. Thank you for the insights at your end, Dr. DeFranzo.
Some controversy.
Absolutely. And that's what it's all about, the debate.
But just want to point out, this really is a very different population than what we're talking about tonight. We're talking about a triple therapy drug in people who don't have advanced cardiovascular disease, renal disease, or have A1Cs of 10 to 12. We're talking about much earlier in the natural history of the disease, where most of the patients are going to be good candidates for this triple therapy drug.
Right, right. Dr. Jayshree, for you then, we have these other existing triple combos already with pioglitazone, with voglibose. What do you feel is going to happen to them with this new triple combination FDC on board now?
So I think the usage of pioglitazone is not, I don't think it's going to be knocked off. It's sort of where it's resting right now, which is not very high up. Whether we're going to be using less of sulfonylurea, metformin, voglibose, those types of medications, I think yes. I think the main reason is, I think we all agree that weight reduction is key. Every kilogram of weight reduction that we are able to help our people with type 2 diabetes achieve that weight reduction, I think it's important. And before Dr. DeFranzo jumps on me about pioglitazone, that's just the way it is practiced here in India. So, pioglitazone is it's used, it's certainly used, but it's not high up there as much as the sulfonylurea and the AGIs. So I think the usage, as was pointed out by one of the earlier speakers, is already going down. If we want something which achieves good glycemic control with weight reduction, with less hypoglycemia, again, I just come back to the fact that these three molecules do it. So, that's the reason why this will probably move up the sort of the therapeutic choices, because you're going to achieve that. Apart from all of the other precautions that other speakers have pointed out, I think soon after diagnosis in someone who does not have renal problems, decent sort of between 7 to 9.5 HbA1c, I think we should consider using this, if not as initial therapy, at least as sort of the certainly a second line medication rather than adding more tablets. I think one of the main, which we haven't touched upon today, I think one of the main advantages obviously of FTCs, as we all know, is that it improves compliance and also it reduces cost. In India, I think that's also an important aspect of making sure that people continue to take the medicine. So maybe it will knock off, to answer your question, Dr. Piya, I think it may sort of knock down the position of sulfonylurea and the voglibose combination, but we have to wait and see. Yeah.
Okay. Dr. DeFranzo, we know your position on pioglitazone, so we won't ask you again there.
Good.
But go ahead. If you have a comment, please do.
No, I mean, there are clearly major misconceptions about pioglitazone, and I think it's a great drug. But I think this triple combination is an effective one. I think as I pointed out, I think on the second slide and by the previous comment, it's easy for patients. It's a single tablet. It improves compliance, and that's a huge problem. And it's going to lower the cost. It corrects a number of the pathophysiologic abnormalities. It's effective in lowering the A1C. You get a little bit of weight loss with the SGLT2 inhibitor, and you get cardiovascular and renal protection with the SGLT2 inhibitor. So this is a very, very nice, effective, safe combination, which is easy for doctors and easy for patients, and it's attacking multiple components of the ominous octet.
Right, absolutely. Dr. Sahay, for you, hypoglycemia, are we likely to see it with this combination at all? Do we need to warn our patients about the possibility?
Well, while all these three agents don't cause hypoglycemia, but we should be aware of the fact that some of them may be on insulin, some of them may be on sulfonylureas, and we need to make them aware that the hypoglycemia may come on if they are not reducing the dose of insulin. They may need a reduction in the dose of insulin. Sometimes the dose of sulfonylurea also can be reduced with the use of this combination. So that aspect has to be highlighted, that they may develop hypoglycemia, and at that point of time, it's not this medicine which has to be stopped, but rather the dose of the SU and the dose of insulin has to be reduced.
All right, great. Dr. DeFranzo, any words?
I think that there would be need for additional study of using this triple combination tablet with insulin. I haven't seen much data on that. So I think a good point, you have to worry about hypoglycemia, but we don't really have much data of this combination. And I think that probably a study to look at that would be indicated.
Right. Dr. Chowdhury, the last one for you. How does this triple FDC fit into current guidelines, and how will it influence future guidelines as well?
I come back to my initial issue of the importance of glycemic control. Now, we have been using various combinations of oral agents, 2, 3, 4 agents, which are not there in any of the international guidelines. But in India, we have been using, and we feel have been profited by the use of these combinations. I do hope in future this reality will be grasped by others as well, and they should also find their place, rightful place in various august guidelines. Whether this triple combination should be used in patients who have been recently diagnosed with an HbA1c which is just off the target, maybe at 7.5%, I think for that we need to have more data. Unless the patient also has got coexistent cardio-renal problems, which would indicate the use of an SGLT2 inhibitor. But if there is a A1C gap of at least 1.5 to 2% that I have been mentioning, where I think this triple drug combination can well be used as the starting point. So yes, I am looking forward to further modifications of the guidelines. And in fact, the guidelines, any guidelines that you may look at, it's interesting and exciting to look at the changes that have come across over the last maybe even 10 years. So yes, I think there'll be welcome changes to guidelines.
Dr. DeFranzo, any opinion about where the future guidelines would go with these kind of combinations?
Yeah, well, I would say India is light years ahead of the rest of the world, because I've been a big advocate of combination therapy for at least 15 or 20 years. You are doing it. I think the European guidelines, the ADA guidelines, are really just starting to introduce this concept. So I think that we really need to move forward in the US and Europe in using drugs in combination. And there are multiple combinations that I think need to be looked at. And even now, to change gears a little bit, like the new GLP-1 receptor agonists, they're fantastic drugs. But now you see everybody is now putting something with the GLP-1 receptor agonist. We have a GIP, GLP-1, we have an amylin combination, a glucagon combination. And I think that's really where we should be going. And of course, those are all injectables. But for the primary care physician, this kind of triple combination oral tablet is really an excellent choice because it makes life easier for the doctor, it makes life easier for the patient, and they work.
Absolutely. I'm thinking at the end of this entire conversation, between these kind of powerful combinations that we have and artificial intelligence, I wonder how much of a practice all of us doctors are going to be left with. But anyway, at the end of the day, this was, I think, a great discussion. Does anybody have any closing remarks for us tonight? Dr. Bantwal, Dr. Sahay, Dr. Chowdhury, Dr. Chandalia, anybody? Dr. Jayshree, Dr. DeFranzo. Dr. Chandalia.
Only comment is we should do it in person next year in India.
Sorry, say that again, Dr. DeFranzo.
Only comment is we should do it in person, not virtually, next year in India.
Absolutely. No such Zoom troubles then.
I just wanted to bring up one side effect of SGLT2 inhibitors. That is, although regulatory trials, very little DKA has been shown. But in practice, especially those of us who practice also acute medicine, and I do that continue on a big scale. So we get roughly about 2 or 3 every year, last 3 years, with definitely DKA with SGLT2 inhibitors. Many doctors know that this has to be discontinued when the patient is sick because they are very sick people, but they discontinue just before patient is admitted. And it's very well known that the effect on production of ketone and acidosis, thereby you see continues for about a week after you stop SGLT2 inhibitors. So I do want to issue a word of caution to all the clinicians who practice acute care medicine as well. But remember, the regulatory trials do not really reflect very clearly what happens in the real life situation. And many of our very, very respected colleagues from other countries are not taking care of acutely ill people. And many of us here don't do, but some of us who are involved in this, we have to refute that it does not cause DKA.
All right. Thank you so much, Dr. Chandalia. And if there is nobody else with any comments, just a few closing remarks on my end. It's great to see the potential of this excellent combination from the point of view of, taking care of compliance, which is a big problem amongst our Indian patients who are pill counters as always. So compliance being an issue, physician inertia, the cost factor, addressing the complex pathophysiology. Here we have a drug that alters the course of disease, glycemic and extraglycemic, taking care of all of those issues. And at the end of the day, to borrow Dr. Chandalia's line, I think not giving these kind of drugs, especially maybe SGLT2 inhibitors, is a disservice. I think we need to find reasons not to give it in this day and age. And when given in a good combination, hitting early, hitting hard, where majority of the patients can benefit from this in the long term, I think will become the order of the day. Thank you very much. And with that, I would call back Dr. Ashish to give his closing comments.
Thank you, ma'am. Thank you, Professor DeFranzo, for joining us today. It was a great learning experience for all of us. Thank you so much. And thank you, ma'am, for conducting this meeting in such an engaging and direct manner. It's a memorable experience for all of us. Thank you, Dr. Chandalia, Dr. Shubhankar Chowdhury, Dr. Jayshree Gopal, Dr. K Sahay, Dr. Ganapathi, and Dr. Surendra for sharing your insights and perspectives. It was a great experience for all of us, and we learned a lot today. And finally, thank you to the delegates for joining us. Take care. Good night.
Thank you, everyone. Thank you so much.
Night.
Thank you.